Hello, everyone. Welcome back to this sort of ongoing series of lectures. This is going to be a long one, so if you're planning to listen to this whole thing in one go, settle in, get comfortable, grab a snack or a glass of water. This is a complex topic, and my suspicion is that given the timing of the week that I'm posting this, many of you will have already, at least I hope, have tried to grapple with the assigned article for this week, which is Epistemic Injustice and Illness by Ian James Kidd and Havi Carel, or however her last name is pronounced. Epistemic injustice is a sort of hot topic in contemporary epistemology right now. This sort of little title card shows Miranda Fricker on the far left and her book Epistemic Injustice, Power and the Ethics of Knowing, which was published by Oxford University Press in 2007. This is sort of the book that put this topic on the map, and even though it didn't seem to generate a ton of literature immediately after its publication, it has certainly picked up in the last 5 years quite a bit. And this article, which came out in 2017, looks specifically at how epistemic injustice manifests in the experiences of ill people in the healthcare system in the developed world. That's a somewhat narrow focus, but they didn't want to look at global healthcare because that would just be way too much to talk about in a single paper. So, main objectives going through this is identify what we're talking about by epistemic injustice. There's going to be a lot of new terminology and a lot of new concepts that come into play. Some of these are related to our discussion of bias, which was the last kind of topic that I was leading us into right before you all took the midterm exam. So there's a sense in which this is a loose continuation of that same idea. And we're not going to be done with epistemic injustice after this week. We're going to see it pop up again, specifically in the context of the opioid epidemic. So it has connections to a number of different things. The other thing I will stress, if you have, before we dive into this, if you've looked at this article, it's got a ton of words, phrases, etc. you've probably never seen before. And I'm not going to define every single one of them here. You have a vocabulary quiz that's kind of it's basically just one big matching question that will test your knowledge of the terms in this stuff. You are going to have to go back and look at the article. All the terms are in the article, every single one from that quiz. But you are going to have to get some of them out of the article itself. You can't, if you haven't tackled that yet, you are going to have to do that. You're not going to be able to get the definition of every single term from this PowerPoint. So fair warning and slight spoiler on that. Anyway, let's dive into this. So, the basic premise of this article, which the authors tell you on the opening page, is that Kidd and Carel want to examine epistemic injustice within healthcare in the developed world, and they also give you on that opening page, I think it's on the opening page. No, it's not on the opening page. Okay, I stand corrected. But shortly into the article, they give you the definition of epistemic injustice. As I said, it originates from this book from Miranda Fricker, Epistemic Injustice, Power and the Ethics of Knowing. The basic idea is that it is a wrong done to someone in their capacity as a knower. So the epistemic, when we're talking epistemic injustice, epistemic is just an adjective derived from the term epistemology. Epistemology is the branch of philosophy that pertains to the study of knowledge. So the word epistemic just means related to knowledge or knowledge related. So epistemic injustice is injustice related in some way to a person's status as a knower or to a person's status as someone who can acquire or has knowledge, something like that. Now if that sounds kind of weird and abstract to you, I'll try to illustrate it with some examples as we move along. Now you might be wondering, why should we care about this weird phenomenon? Why should we be concerned about epistemic injustice? That seems like a sort of weird academic term that has no applicability to the real world. Kidd and Carel offer two reasons related to physician and patient complaints that are put forward in hospitals and other clinical contexts that pertain to communication between these two parties. So before we get into that, back up. The basic idea here is that physicians often complain about patients bringing up information that's just irrelevant, that doesn't really have any value or pertain to the best treatment that they can get. And patients complain about not having their voices heard by physicians, having their perspectives dismissed, feeling like they're kind of cut out of the decision-making process. So what this results in is a sort of friction between patients and physicians that erodes the sort of the trust and foundation of their relationship. They tend to complicate and sometimes even compromise the epistemic relationship between the two parties. So if you're a healthcare professional and you don't take the perspective of your patient seriously, then that may cause you to make decisions more unilaterally, right? Because the input from your patient, in your view, doesn't matter all that much. On the other side of that, if you're a patient and you feel like your perspective is not being given a fair hearing, you might just withhold information, not want to waste your time talking to your doctor or your physician. And as a result, you might accidentally withhold information that would actually be very important for them to have. So it cuts both ways. It disadvantages both parties. And the other reason to care about this, besides like the kind of, case-by-case harm and complications they can create, is that these kinds of complaints lodged by patients and lodged by physicians are long-standing and evidence of a systematic issue in healthcare and other medical professions. It's not something, this isn't just a one-off, it's not something that's brand new, it's something that's been around for decades, at least if we're talking again about healthcare in the developed world, which is the author's main focus. So we've got, in other words, a systematic, long-standing problem in the relationship between patients and physicians and in the ways that they interact. So this paper is essentially an attempt to diagnose what the problem is, and then at the very, very end, we get some kind of vague gestures toward potential solutions. Here are the main theses of this paper. Now, one of the things I will say about this paper, it is dense, and if you've grappled with it already, you probably know that. But it's also very well organized, and the authors are very explicit, much more explicit than some of the authors we've read previously in the course, about what they're doing. So on page 175, they clearly say, here are the theses of our paper, and they identify two. And if you don't believe me and you want to pick this out, it's the first two paragraphs on page 175. First thesis they identify, they want to defend the claim, those who are chronically ill are especially vulnerable to epistemic injustice. And the second claim, the concept of epistemic injustice can help to explain, at least partially, patients' complaints about their healthcare experience. So this paper is an attempt to diagnose a problem. It is not going to focus on how we solve the problem. It's mainly going to try to just give us insight into what the problem is, how it persists and perpetuates, and what negative effects it has. Now, another thing I'll point out, because, again, this is a dense article, very complicated, it's worth highlighting how the article is organized. The authors are very clear about the topics they're going to cover, and, unsurprisingly, they cover the topics in the exact order that they say they are, and all of these topics are designated by section titles. So again, this is a dense article, a lot of new terminology, pretty abstract in certain places, but it's well organized, and it's pretty clearly written. So the first topic they're going to talk about is testimonial injustice in general. Testimonial injustice is typically taken to be the paradigm case of epistemic injustice. So we'll spend a little bit of time about explaining what that is and again, trying to illustrate with some examples. After that, they talk about two specific types of testimonial injustice: participatory prejudice and informational prejudice. Interestingly, these two types of prejudice are, as far as I can tell, the only parts of their paper that don't draw primarily on Miranda Fricker's framework. Participatory prejudice and informational prejudice, at least as they present them, seem to be kind of the author's own ideas. The last major topic they talk about is hermeneutical injustice. You have probably never seen the word hermeneutical before. It is a $5 word that means related to interpretation. So when we're talking about hermeneutical injustice, we're talking about injustice that pertains to how people interpret their experiences of the world in some way. Now, the definition they give in the text is a little bit more complicated than that, but that's the basic idea. So hermeneutics is a study of interpretation. Hermeneutical means related to interpretation. Commit that to memory because, my God, you see it so much in this article. This will be more times for most of you than you will see the word hermeneutical in the entire rest of your lives. Now, for each of these three broad topics that the authors treat, they say, in each case, we ask whether ill persons are especially vulnerable to that type of injustice, and if so, identify the stereotypes, structures, and practices that generate and sustain it. So, each section that they go through, they say, here's a general type of epistemic injustice. Here's how ill people are particularly vulnerable to this kind of epistemic injustice. And here's why they're particularly vulnerable to this kind of epistemic injustice. And they do that with all three of these topics, and then more or less wrap up their paper in the concluding section. Okay. Now we get to the real meat of the article. So the first big heading here, testimonial injustice. What is testimonial injustice? Broadly, testimonial injustice occurs when a person's testimony is not taken seriously due to prejudice. Now, I want to pause here and make a big caveat. The due to prejudice clause is absolutely critical to this definition because, as we all know, there are situations where it is completely appropriate not to take a person's testimony seriously. Maybe you have a friend who is prone to exaggeration, or a friend who's just outright dishonest. If that's the case, then you have good reason to take that person's testimony with a grain of salt, or, if you prefer, if you're not familiar with that colloquialism, to take their testimony as tentatively being true, but with a healthy dose of skepticism. There are also certain contexts where not taking a person's testimony seriously might not be based on like a personal relationship with the person, but it might just be based on certain norms that are in play. So if you're playing poker and someone tells you, quote unquote, what hand they have, or tells you that you should fold, or something like that, that's not a context where you can trust that they're telling you the truth, obviously, right? Because bluffing, which is essentially deceiving someone about the quality of your hand, is an essential strategy in any game of poker. So you can never be confident that anyone at a poker table is telling you the truth. And that's not because you're a prejudicial asshole that you believe that. It's because you understand the rules of the game, and because the context there is different. So not all instances of failing to take a person's testimony seriously, not all of those are wrong, and not all of those are due to prejudice. So those are not going to be cases of testimonial injustice. Testimonial injustice is a special case where it is in some way unethical or wrong to not take the person's testimony seriously. Now, often, testimonial injustice occurs because of stereotypes that are in play in a particular context. So certain people face a prejudicial credibility deficit in certain contexts. Here's one example. Suppose that you are a woman who happens to know quite a bit about cars, and you're trying to give someone advice on how to fix a car engine. I've heard from spending too much time on Reddit that there are many women who have explained to men how to do things. They have professional credentials. Like these aren't just random women. They're people who are employed fixing cars, and they will give men advice on how to fix their car, and they will run into situations where the men will go and then check with male mechanics working at the same place, or they will then explain why they disagree with the mechanic's judgment and engage in the age-old process of mansplaining. You may not have heard that. If you haven't, you can look it up on Urban Dictionary or wherever. Mansplaining is essentially where a man who knows far less about a subject than a woman nonetheless explains to the woman what she doesn't know or what she has wrong. If you are a woman who is in a dominantly male profession, you are in a significant credibility deficit just because of your gender role. Just because people will question whether or not you really have the qualifications, not based on your actual lack of qualifications or on your bad service, but simply because you're a woman. That's a classic case of testimonial injustice. If they don't take what you say seriously just because you're a woman, it's a pretty cut and dry case. Another example that comes up a lot in this context, and it comes up a lot because it was one of the main examples that Miranda Fricker used in her book to illustrate this concept, is Tom Robinson in Harper Lee's To Kill a Mockingbird. Tom Robinson is accused in that novel of raping a young woman, which he did not do. And all of the evidence, the physical evidence about what took place, suggests that he did not commit, that she's actually harmed by someone else in the story. And instead of that person owning up to, essentially, I believe it was her father, instead of owning up to abusing her, he fabricates this story that Tom Robinson raped her and that's how she got injured. And Tom Robinson essentially, so another important piece of context, when he's testifying, the jury is all white men. So he is in an enormous prejudicial credibility deficit in this context because he's trying to defend his innocence in a community that has racist values against an all-white jury. And unfortunately for him, although he gets a spirited defense from his lawyer, the story does not play out well for him. I won't say more than that. It's a classic novel. You probably read it at some point in the past. It was something I read in high school. But yeah, Tom Robinson, big time case of a victim of testimonial injustice. And for a more lighthearted example, because that's a little bit heavy, I'm going to reference Utopia again. And yes, I did this once in a lecture a few weeks ago. I can't promise this is the last one. There is a scene, I will post a clip to it in the video segment for this week. There is a scene in the film where Officer Judy Hopps is trying to explain how she and Nick Wilde, the fox in question, were attacked by a jaguar that had seemingly lost his mind and, as she put it, gone savage, and attacked them and tried to kill them, eat them, whatever. And when she gestures to Nick to provide his testimony, the chief of police, who's a large and imposing water buffalo, just says, "You think I'm going to believe a fox?" The implication being that Nick, by virtue of his species membership, being a sly, shifty fox, cannot possibly be a credible source of testimony. Not because what he's actually said is dubious, not because he wasn't there or doesn't know anything about it, but just he's a fox. That's all you need to know. He's not trustworthy. So that's another case where Nick faces, because of his species stereotype, faces a prejudicial credibility deficit. And in that particular context, his testimony is not only not taken seriously, but dismissed before he even gives it in that particular context. I will again include a clip to that scene if you want to check it out. So that's testimonial injustice. Now, all right, that's all in the abstract. Now we got to make the connection to what's happening to ill people in the medical profession. So remember, go back to the definition. Testimonial injustice occurs when a person's testimony isn't taken seriously due to prejudice. So when we're talking about ill people, we're talking about prejudice against the ill, right? That's the context. So the testimony of people who are ill is often discounted because of stereotypes such as the following. Well, ill people are cognitively impaired or cognitively deficient. Ill people are emotionally compromised. This typically, the idea behind this one is that people who are ill, especially if it's a serious illness, might just be sort of caught up in the moment of, the news of their diagnosis or the stress that's caused by being sick or being in a hospital or whatever. In other words, they're not fully in control of their rational capacities. They're acting just on emotion. And so in that respect, their testimony can't be given the same kind of weight the weight we would give to a normal, level-headed person talking about the same stuff. Third stereotype, ill people are existentially unstable. That's the author's phrasing for this. And one common reason might be because their condition is terminal. So existentially unstable might sound a little bit dramatic, but the idea is that, again, certain ill people are just not in the right kind of mental state to discuss the subject matter rationally. And the last one that the authors mention, ill people are psychologically dominated by their illnesses such that they cannot describe them accurately. So you'll notice that all four of these that are on this list, they all pertain in some way or another to the idea that just because you are ill, you are in some way irrational or otherwise incapable of discussing your illness in a composed, rational way. Now, when it's put in such a bald-faced way, it's obvious that this perspective is extremely uncharitable to people who are ill and not in any way representative of their actual perspectives or ability to articulate their feelings and such about it. Notice something important here. I'm going to make a callback to our reading on informed consent by Meisel and Kozutsky. Remember that they wanted to perceive informed consent as a model of shared decision-making, right, where patient and physician are in dialogue and trying to collaboratively make some kind of a choice about what treatment option is best for the patient. These stereotypes are a direct threat to the honoring of informed consent because they all encourage physicians to disregard the perspectives and shared experiences of the patients in these different situations. So even though Kid and Carel don't ever talk about informed consent, I want you to recognize there's an obvious connection here where testimonial injustice, if it's occurring, is almost surely going to interfere with the ability to honor the obligations of informed consent that we talked about earlier in the course. Now that's testimonial injustice. So the idea here is, sometimes the testimony of patients isn't taken seriously because of these various stereotypes that are in play. But that's only one type of potential epistemic injustice that they're vulnerable to. Another one is participatory prejudice. This takes place when a person or group is prejudicially thought to lack a, quote, sense of relevance. Now, a sense of relevance in this context basically means a sense of what ideas and input is relevant to the subject matter at hand. So any collective epistemic activity that we engage in, whether we're debating with one another about a policy issue, conducting research about some topic of mutual interest, collaborating perhaps on a creative project, whatever it is, there are always going to be a couple of key assumptions made about the participants in the activity. First, everybody involved understands what ideas are worth pursuing, at least in some broad sense. So so for example, let's suppose we're doing academic research. Well, if I'm doing a collaborative research project with a fellow philosopher, we're probably going to be on the same page and we're going to have pretty similar understandings of what ideas are worth pursuing. But if I was working with, say, a mathematician, trying to, prove some kind of complex mathematical theorem, I would have no idea how to go about doing that or what ideas to put forward for how we might, search for a solution. I would not have, in that context, a sense of relevance. Importantly, that would not be a case of participatory prejudice because my lack of a sense of relevance wouldn't be other people wouldn't think that about me out of prejudice. It would just be because I didn't have the education, right? I didn't have the background that would be necessary. So it's not a prejudice. It's just, it's a fact, basically. The key ingredient to participatory prejudice is prejudice, right? It's the idea that the reason why you're perceived to lack a sense of relevance is something that has to do with group membership, right? Some kind of a bias against a group that you're a member of. The other big assumption about participants in these collective epistemic activities is that they can provide information that contributes to the task at hand. So you understand what ideas are worth pursuing, and you can provide information that contributes in some way to completing whatever task you're embarking on. So participatory prejudice affects ill people because most of them are not in position to understand what ideas are worth pursuing when it comes to epistemic practices in medicine. This is because most ill people don't have a deep background in medicine and are, to some extent, dependent on feedback from physicians and other healthcare professionals to help them make decisions. Now, notice, though, this is not the same. Saying that they don't have, a deep medical background does not mean that they can't have input on what kinds of treatments they would prefer or which ones they think would be best, right? Again, this goes back to a discussion of informed consent with Meisel and Kazutsky. They talked at one point in their article about how you don't need to understand something to the same extent that a medical professional does to be able to make an informed decision about that thing. Now, there is a certain extent to which medical professionals need to be able to communicate the basics, right? Some of the basic components of treatment, the expected outcomes, things like that. But they don't need to give every single conceivable detail, nor do they need to expect that their patients have to understand those ideas to the same extent that a medical professional does to be able to engage with them and to have relevant input. The other problem that ill people face is that they're often regarded as objects of medical practices rather than participants in those practices. So, again, this is a kind of reasoning about the ill where instead of being seen as collaborators with physicians, they're being seen more as bystanders, right? This is the kind of perspective that, again, encourages a sort of unilateral decision-making by physicians, or at best, a diminished, putting patients in a position where their role in the decision-making process is heavily diminished. And because of that, ill people are often not able to participate in the decision-making process, even the decision-making process that directly affects them, as a result of this kind of prejudice about, ill people's perspectives and the value of their input on these things. So that's participatory prejudice. Now, different kind of prejudice, informational prejudice. This occurs when a person or group is prejudicially judged to lack the ability to provide relevant information in a given context. And the authors say that this can occur in two ways. First, information from a particular group or person is automatically regarded as irrelevant or insignificant. And second, assumptions about what information is relevant or significant are not open to discussion. These are mutually reinforcing. Again, that's super abstract, so let's try to say a little bit more, perhaps in more ordinary language. The idea here is that you have an epistemic context where the norms about what kind of perspectives matter, where the norms regarding that are set in stone and not really up for debate, and they, whether explicitly or tacitly, exclude the perspective of some particular group, or at least in some contexts it could be a specific person. The idea here is that when you have, a group making a decision about something, say, or again engaging in some kind of collaboration or group project, that there is some kind of particular group that they just offhandedly dismiss or don't allow into the conversation. If you look back at the history of philosophy, there are some people recently who I think have argued somewhat persuasively that minority perspectives, if you go back a few hundred years, minority perspectives, particularly from people from non-Western philosophical traditions, that their perspectives were just not taken as seriously by other people in the profession as people who were, say, white Europeans. And some of the evidence for that is the fact that so many of the historically significant figures in the field of philosophy are white men. That's been starting to change over the last several decades, but if you look at it historically, you go back to the 1700s, 1800s, or especially before that, it becomes more and more difficult to find really, really influential and widely cited philosophers who are not European men. And one of the reasons why was because there was this sort of informational prejudice going on where the people who had the best perspectives and the people who had the most valuable insight were people all coming from this kind of Western European tradition. And the result of that is that if you weren't a member of that tradition, then your perspective was sort of systematically discounted over time, or just tacitly regarded as irrelevant or insignificant. It is perhaps unsurprising that a lot of people who were writing in the 1700s and 1800s from that Western European background, we also now know from their biographies that they had profoundly racist beliefs about certain things. And so that undoubtedly played a role in it as well. Now that's admittedly just one example. Let's look at it in the context of ill people. How do ill people, how are they particularly vulnerable to informational prejudice? Well, the first way is that sometimes information they provide, and these are examples from the authors, bodily estrangement or social isolation, sometimes the information that ill people provide is just dismissed as being irrelevant. Again, not because of the content of the information. It's simply because these people are ill and the perspective that they have on this can't be trusted. Now, this importantly harkens back in some ways to that slide that I had earlier with all the stereotypes listed. Because one of the reasons why you might be prone to dismiss the perspective of ill persons is because you harbor one of those stereotypes, right? You think these people are, generally just too emotional to have a perspective that's worth taking seriously, or these people, are generally not cognitively with it. They're taking medications that might alter their behavior or their personality in ways that make them irrational. We can't, you just can't trust their perspective, right? If you have those kinds of thoughts on the subject, then obviously you're going to be prone to exclude the information that ill people provide. And in doing so, you're putting them in a tough situation because you're basically blocking them from providing relevant information. And the other big one that the authors mention is that medicine is still a context, as many professions are, where objective information is prioritized over subjective information, or as I've put it here, self-reported information. What this means is, in a medical context, a sort of written up diagnosis from a medical professional about what your blood pressure was, what your heart rate was, what your cholesterol level is, what symptoms you have, all that kind of stuff, that carries a different kind of weight in this context compared to a patient simply reporting, look, I'm suffering from chest pain, or look, I've been having joint stiffness for weeks, in my elbow, and I don't know what the problem is. Because of that, there's going to be a tendency to always give the greater weight in how you in what you recommend to patients and in how you diagnose them to your spreadsheet or your form or your formal diagnosis or whatever it is, and to kind of disregard or minimize the significance of a patient's subjective experience. In one of the discussion posts I saw earlier this term, somebody mentioned when they were young, very young, like under the age of 10, consistently reporting a certain type of joint soreness that basically always plagued them for years. And she just could not get other people to take it seriously. And it wasn't until she got old enough that people started taking it seriously that she actually was, diagnosed with an actual condition. But she'd had the condition for years and just went years in pain and without treatment because nobody took her perspective seriously. That was a clear case of informational prejudice. Now, it wasn't because she was ill, it was because she was a kid, right? She was too young to be, to be a reliable source of information or something like that. And her subjective experience was systematically discounted by all these people that she interacted with as a result. So at least some people in this course have actually already experienced some epistemic injustice in their own lives, which is unfortunate, but it speaks to the commonness of the phenomenon. It shows that this isn't just like an abstract thing that we're studying just to do a little epistemology on, during our free time after the midterm. This is something that does affect people's actual lived experiences. Now, beyond all this stuff that has already been mentioned, there are also a few practical complications that come into play with these different forms of epistemic injustice. I'm sure these are not all of them, but these are the ones that Kidd and Carel mention. Every single one of these practical complications increases the risk of ill people experiencing testimonial injustice. One practical complication that increases this risk is that healthcare professionals have to meet targets and performance indicators. So, in other words, they've got to see a certain number of patients, they've got to meet certain outcome requirements for those patients. They can't just spend tons and tons of time with every patient that's under their care. That means that they're sort of incentivized by the system to take on a lot of patients and to limit the amount of time that they interact with them. Now think about that. When you're limiting the time, when you're basically saying, I'm a physician and I can only allocate I have no idea what the normal number is as someone who is not a physician himself. But suppose that you could really only meet, you had, I don't know, say 20 patients, you can only meet over the course of a couple of days with each of them for about 15 minutes, given your schedule. Your goal as a healthcare professional then is going to be maximizing, from your point of view at least, maximizing the amount of important information that you can discuss in those 15 minutes. And most likely, given the norms of the medical profession, that's not going to involve spending a lot of time listening to them talk about their subjective experience of the treatment they're undergoing or how their recovery from, some procedure is progressing or whatever. Most likely, you're instead going to go over a series of objective measures of like, all right, here's how, on my diagnosis you're progressing. Here are some things that are good. Here are some things that are bad. Here's the medication we're putting you on. Here's the dosage for it. Here's what you should expect. This doesn't mean that no physician is going to give you an opportunity as a patient to provide your perspective. The point is there's some background incentives here that kind of encourage healthcare professionals to minimize the amount of time that they spend interacting with patients in the ways that would give them opportunities to present their own perspective and to have that perspective taken seriously. Another one is that physicians have an obvious incentive to distance themselves from patients, particularly patients who have very grim diagnoses. I mean, if you were a medical professional who got super wrapped up in the goings-on of every patient you had, you would just be emotionally devastated so often because some of these patients, their conditions might be chronic, they might never recover. Some of them have terminal conditions where their ultimate fate is going to be death and their condition, they cannot be cured. That's a rough situation. And so psychologically, you're almost forced as a physician to maintain a certain degree of distance and to view your relationship with your patients as a professional one where you're really just trying to do your job. And because of that, you may not want to get a whole lot of information from your patients where they're kind of telling you how their subjective experience is going, right? You might not want that information because you might not want to get psychologically attached to them. And the other big practical complication, this is a really important one, responding to participatory and informational prejudices would require significant reforms to medical education and training. It would require not just kind of a shift in physicians' attitudes toward how they interact with patients. It would require us to make a serious effort to go back to kind of the building blocks of how people get into the profession in the first place, make them aware of these phenomenons, and encourage professional norms and other behaviors that would fundamentally change the way that physicians interact with patients. It would not be an easy task, and it's not the kind of thing that immediately after implementation it would lead to huge changes either. It would be a long-term incremental improvement in how this education and training went down, and only after probably a generation of doing that would you start to see really, really significant results, because it would take that long for people just entering the medical profession and beginning medical school or their graduate program in pharmacy or whatever they're doing. It would take a long time for them to get their degrees, get into their residencies and other professional trainings, and then get into hospitals where they can actually start interacting with patients more regularly and taking on more robust professional roles, and then you'd start to see that kind of change, institutional change from the inside out. That would take a long time. So unfortunately, epistemic injustice, at least in the near future, is going to remain a consistent feature of a consistent vulnerability that ill persons are subjected to. Now, that's not all the different types of epistemic injustice that are covered in this article. There's one more. Now, I've already mentioned that hermeneutical is just a fancy word for related to interpretation. So, hermeneutical injustice is kind of like injustice related to interpreting your own experiences. But here's the author's specific definition from the text. Hermeneutical injustice occurs when a gap in collective hermeneutical resources puts a person or group at an unfair disadvantage when making sense of their social experiences. So that's a bit of a mouthful. The idea here is that hermeneutical injustice takes place when there's no way for a person or a group of people to express what their social experience is like to other people for one reason or another. They either can't interpret it, or they can interpret it for themselves, but they can't express it to others. But that's the core idea. According to the authors, this can come about in three ways. First, there could just be a global lack of hermeneutical resources. So this would just be a scenario where nobody has the means of expressing whatever the particular phenomenon is. So one kind of well-known example of this is when it comes to sexual harassment. If you were someone who was persistently being sexually harassed, say in the workplace or wherever, but you existed in a time when the phrase sexual harassment did not yet exist and was not a commonly understood term, you would have a really hard time expressing what was happening to you, and an even harder time doing it in a way that other people could understand and engage with. The second way that this can happen is that the hermeneutical resources of one group aren't recognized or accepted by some other dominant group. So the people in the more marginalized group, they have the means of understanding and articulating their experience, but for some reason, their way of doing that, however they go about doing it, whatever language or expression they use, is not accepted by another group that's in a position of power. And so as a result, their experiences of the world are fundamentally discounted from the collective point of view. And the third way, this is the author's own term, is epistemic isolation. So hermeneutical injustice can occur when a person or a group lacks knowledge of particular information or just doesn't have access to it. So there can be situations where, unlike the second case, where the resources, like one group has the resources, but using those resources is not sort of accepted by the dominant group, epistemic isolation is where maybe that group doesn't actually have access to those resources, or maybe they just don't even know they exist. They would have access, but they don't because they don't even know that the resources in question exist. So this might be, these might involve kind of cases where a person or a group of people are sort of cut off from information or sheltered due to like prevailing social norms or other things that are in play, where they don't, they just don't have access to the relevant information. So for example, suppose that you grew up as I did in northeastern Kansas in the 1990s. If you grew up in that environment at that particular time, there were really only two sexual orientations. You were either gay or you were straight, and that was it. There was nothing else. And you really didn't want to be gay because it was not favorable socially to be gay in the 1990s. I'm just putting it mildly. That may be hard for you to believe because there was an overwhelming sea change in the, from the year 2000 to 2010 in the United States on this kind of the way that sexual orientation was perceived. But back in the 90s, trust me, that was the way it was. And especially in, states and other cultural contexts with a dominantly conservative outlook or value system. And if you were someone growing up in the 1990s in that area and you were, say, bisexual, you were probably in a state of epistemic isolation because you probably weren't even aware that that was a viable sexual orientation. Especially since if you ever introduced that concept, people would likely say like, oh, bisexuality is just a phase, or that's not a real sexual orientation, or you're just pretending to be gay, or any of these other ridiculous stereotypes about bisexuality. So if you were a person growing up in that context and you were actually bisexual, you would probably not be able to, you either wouldn't know what it was, or if you did, you wouldn't actually be able to express the idea and have it taken seriously by other people. So you may well find yourself, with respect to expressing this aspect of your identity, you might well find yourself in a state of epistemic isolation. Okay, so how does this connect to ill people? Typically, those who are ill experience hermeneutical injustice because the resources required for the understanding of their social experiences are not accepted as part of the dominant hermeneutical resources. So, if we're going back to these types, it's usually, not always, but usually going to be number 2 on this list. Now, one of the phrases that has been thrown around these last couple of slides and gets thrown around quite a bit in the article is hermeneutical resources. There's nowhere that the authors define this in the text, what exactly they mean. The best that I can come up with from the context and from rereading these passages several times is hermeneutical resources refer to a vague term for the ways in which people can interpret their experience of the world. And this could include anything from their use of language, their means of emotional expression, their representation through artwork, stories, whatever have you. Basically anything that involves the expression of that experience. And so when we say those who are ill don't have the hermeneutical resources, or excuse me, their hermeneutical resources required for, expressing their social experiences aren't accepted as part of the dominant hermeneutical resources. What we mean is ill people can describe their experiences, perhaps, to some degree. But these experiences are often not considered appropriate for public discussion, or don't play any meaningful role in clinical decision making. So they've got the means of expressing what their experience of illness is like. But the idea is these kinds of things that they say or explain to others are either kind of considered private information that shouldn't be publicly voiced, or are otherwise discounted in the medical context when it comes to making decisions. So because of that, there's a sort of gap here between if you're a patient in certain situations, at least, there are going to be situations where you're trying to make sense of what it's like to experience this illness, but you're getting these cues from the world around you that you shouldn't be trying to do that. You shouldn't be trying to interpret that information or present it to medical professionals, because either it's not appropriate to discuss or they're not going to care and they're just going to dismiss it anyway. So if you're an ill person, what this means is that there are going to be situations where you have more difficulty making sense of what you're going through when you're ill, where you're unable or unwilling to discuss the matter with your healthcare professional for fear of, rejection or it being considered a violation of social propriety or whatever. And as a result of those things, you may wind up withholding important information from your physician that could actually improve your treatment, or at least make you feel better about your experience. So, not a great outcome in that situation. So, I'm going to close here by thinking a little bit about the solutions. The authors gesture vaguely in the direction of some possible solutions, but the main point of their paper is kind of a diagnosis, not so much a, call for reform or whatever. It's, here's the problem. Here are maybe some things that we could try to do to prevent patients from becoming victims of epistemic injustice in the future. The first two things are basically what their article does, right? Before you can come up with a solution to the problem, you've got to diagnose the problem. That's a lot of what they've done. You also have to identify what aspects of the medical profession make patients vulnerable to epistemic injustice in the first place. Again, they've done quite a bit of that. Once we've done that, the big thing we've got to do afterwards is we have to find a way to provide ill people the means of overcoming these barriers to expressing their experiences and having their perspectives taken seriously. That's easier said than done, because it requires, they speak at the very end in one paragraph about the crafting of a, quote, phenomenological toolkit to help patients understand what they're going through. I'm not sure exactly what they have in mind there, because they make a reference to, phenomenology, which is an area of philosophy I've got very little exposure to. And they don't elaborate much on what they're saying, but I gather that the core idea is that you try to give people who are in these unfortunate circumstances resources, whether they're hermeneutical resources or just, improved attention from medical professionals, whatever it may be. You give them resources through which they can actually express what their subjective experience is like, have it taken seriously by others, and possibly have that information used to suggest particular treatment options or to, in some other way, improve their actual medical outcomes. And the last one, which is probably the biggest one, reform the institutions that are involved in all this to reduce the extent to which epistemic injustice takes place. This would be something that goes well beyond just encouraging physicians to take patients' perspectives a little more seriously. It would involve significant changes to how we engage in medical education, how we educate doctors, how we allocate time that physicians spend to patients, how we change professional norms regarding physician-patient interaction. There would be a hell of a lot of work to do to accomplish number 4. So hopefully after, reading this article and kind of going through this discussion, hopefully we're at least better positioned with number 1 and number 2. Accomplishing 3 and 4, that's kind of like work to do in the future. But before you can work on solving a problem, you got to get clear on what the problem is. So this was a rundown of epistemic injustice, both in general and with its connection to healthcare. I hope it was helpful in making sense of what is probably our most difficult reading of the semester.